we'll make a start. Very brief introduction from myself. So I'm Rachel Barham. I was formerly Forbuster, keep forgetting what my surname is. And it's really great that you've all been able to join us this afternoon. So just to give you a little bit, for those who don't know, we've been running the Digital Inclusion Forum. We run 5 per year, and we've been running this for nearly 4 years, and we've built up a really good group of people who like to come together to share best practice and to find out some hot topics in digital inclusion. So we will be asking people to make sure you've got mute on so that we've got the attention to our speakers. If you accidentally unmuted yourself, you might find Leanne mutes you in the background, but that's just to make sure we haven't got any background noise at all. So you'll notice that the session has been recorded. We will circulate this after the event, so you will get that dropped into your email, but it also enables other people who haven't been able to join for other commitments to be able to come along and listen and find out about the content as well. Please note the CC captions can be turned on at the bottom of your screen, so if you do need to use those, then that's very easy to do. And we've also got the use of the chat function, so if you've got any questions, then please pop them in the chat. We've got quite a full-on agenda today, so there's probably not going to be a great amount of time to answer some of those questions, but Leanne always does a great job in getting responses back to people afterwards, should there be something that we haven't been able to cover within the time frame. So just to mention a little bit about ourselves, Health Innovation North East North Cumbria. We're formerly the Academic Health Science Network, and we're one of 15 across the country. We were established by the NHS England in 2013, so we're kind of 12 years into delivering innovation and spreading that across our region. We also work with all of our academic partners, the NHS, as well as NHS innovators, local authorities, third sector, etc., etc. So we're really kind of that glue in the system, helping to pull people together and try to get innovation over the line. Digital inclusion to me is really important because it doesn't matter what project we help and support, we need to consider those digital inclusion barriers where there's a patient involved or a staff member who might need some additional support. And just to mention our 3 core objectives, which all of the HINs are commissioned to deliver, is something around patient safety, ensuring that we improve the population health of our citizens across our whole geographical area, but also to work with innovators and look at supporting and generating economic growth across our region, and trying to plough that back into our region, which is really good. So I'm absolutely delighted today that we've got 3 brilliant speakers covering 2 slots. So we've got Mary Lavender. She's a speech and language therapist from Cumbria at Northumberland Tyne-Wear NHS Foundation Trust, so CNTW for short, which is what most of us call it. She's joined by Beth Molan, who is not only a trustee of Communication Matters at the UK Charter of Isaac, but she's here today to talk and demonstrate how she uses augmentative and alternative communication aids in order to make sure that she can articulate and communicate with people. What I'm really excited to see as well is Beth's also a Paralympian, but she also gained a PhD for all of her advocacy work. So we're honoured to have her as a guest speaker today supporting Mary. And then finally, we've got Sonia Townend, who is Head of Digital Systems and at Ways to Wellness. And Sonia comes with a really great depth of knowledge around digital inclusion and what they see on the ground on a daily basis, is going to share some case studies with you. That was easy for me to say. So first and foremost, I'm going to hand over to Mary and Beth. I'll stop sharing my slides. And Mary and Beth, it's over to you guys.
Thanks, Rachel. We'll just be getting our PowerPoint up. And thank you, Rachel, for doing the abbreviation to CNTW. I really appreciate it. Yes. So
we
hi,
use far too many
everybody.
acronyms.
There is, but I do appreciate you starting off with it. So yeah, welcome everybody. It's really great to be here today. So Beth and I are gonna present on digital inclusion and what it means to us. And both of us are all about advocating for change, for positive change. And we really do appreciate the invite, Rachel. So thank you so much. So if we just go to the next slide, I'll tell you a bit bit more about myself. So like Rachel said, I work in CNTW NHS Trust. And I have actually 3 job roles. I'm a speech and language therapist, working within the area mostly of AAC, which we will share a lot about today. And I'm also digital health and digital inclusion lead in the trust, and I chair our disabled staff network. And you might not see it today, but I see on a daily basis of how actually all my 3 roles interlink all the time on the topic of digital inclusion. I am also going to share a little bit about myself. So that is something that I don't mind, but also appreciate that I am being vulnerable by sharing things personally, and the same with Beth. So I am disabled, I have an upper limb difference, and I'm also autistic. I'm really passionate about advocacy for disability inclusion and digital inclusion, and I have been for many years. So I've probably worked with global tech companies for probably over 20 years. I've been a speech and language therapist for about 25 years. And I can honestly say the global tech world of disability, whether it's disability tech companies, whether it's the mainstream tech companies, they're really pushing boundaries in digital inclusion. And we can do another session on that at another time, but the amount that has been happening in the disability tech world for years and years that probably everybody today takes for granted because it eventually reached the mainstream market is unreal. And the disability global community is amazing. And also the disability tech companies and just generally the AAC community, which is where I know Beth. So when Rachel asked me to present today on all the different things that I do here in CNTW, when she asked me about my speech therapy part, I was like, I would really love to be able to do that with an AAC user. So I'm so grateful that Beth said yes to my invitation. So just some other things. I've spoken at the House of Commons on the importance of assistive tech and various other Westminster meetings and things, and national keynote speaker and international speaker as well. And in 2024, I received a scholarship to attend the ATIA huge conference in America. So that's open to everybody, by the way, on assistive technology. So if anybody wants to apply in the future. My hopes are that I always want to be able to inspire others to dismantle barriers and have honest conversations about closing the disability gap and how we can all enable individuals to thrive in society and the workplace, and for individuals to receive and be supported with the digital solutions and other adjustments that they need to be able to thrive. And I'm thankful that I'm now going to hand over to Beth to introduce herself.
Thanks, Mary. I'm humbled to be invited by Mary to share this session. My ethos in life is to dream big, work hard and be resilient. Nothing I've achieved has been handed to me on a plate, although assistive technology has leveled the playing field, enabling me to be here today. The honorary doctorate is testament to doing what I've been passionate about all my life. Advocating for and empowering AAC users. And my academic qualifications are a direct result of my determination to make a difference. During my undergraduate degree, I was a dual career athlete, training and competing first for England, then for Great Britain, making it to the Paralympics in Tokyo in 2021. I've been lucky to be able to leverage my status as a Paralympian to gain a platform to speak out for others who use AAC. Along the way, I've been asked to support many initiatives, but I have chosen to focus on AAC. I feel privileged to have my voice, and few people really know the challenge of having little or no speech. So, here I am, an advocate and researcher, with a passion to ensure everyone, whoever they are, and whatever their age, fulfills their own communication potential. Back to you, Mary.
Thanks, Beth. And I'm sure you're going to be really, I am just so thankful that you'd said yes to this. Beth is absolutely amazing. So what are we aiming for and why does it matter? So just a bit about the digital inclusion agenda when we're looking at it from like where we're coming from, I suppose, and hopefully where a lot of you also are coming from. And for us, we want to reframe the narrative. So about disability. Disability is part of the human experience. And for too long, so many people have seen disability or disabled as bad words or autism as bad words. But actually, it shouldn't be. We need to start talking about it more and more. Accessibility is a fundamental human right, which I'm sure many of you know that on the call. And that also includes communication as a human right. And we know, Beth and I know, that too many people do not have the communication, digital solutions and the support that they need to be able to communicate, which when you think about human rights is horrendous. We want for disabled people to have the assistive technology and digital solutions they need. And it's about normalizing and prioritizing assistive tech. We want to be able to break down the many barriers and smash the ableism. If you haven't heard of ableism, that we can come back another day. And in CNTW, our trust board, are having a development session on ableism in January, hopefully in January, just because it's so important for people to understand what it is, especially in the health sector. Pamela, if you want to just put in the chat about the DSN Lunch and Learns and some of the things that we've done just on so many things on our disabled staff network, lunch and learn sessions of just trying to increase people's awareness. And we want to be able to make sure no one is excluded or left behind, and about allyship and commitment. And I think today, following from what we may share, it'd be great if people could get in touch with us and have any actions or just help in this with what we're trying to do. If you can go to the next slide. So I don't know if any of you know this person. I don't know if he is on the call or not, if he's managed to get here today. He's a very busy person. So this person here is Kev Scully, and he is the CEO of North East Ambulance Service. And before he went to be the CEO there, he actually was the exec sponsor for our disabled staff network in CNTW. And he heard many disabled staff talking about just the barriers and just the hardship. And some of it did relate to not getting the digital solutions they needed. And we had many conversations. And it was one day we were saying about I was saying there's too many ableist barriers. Then he turned around and just said that barriers are there to be broken. So let's get the sledgehammers out. So I've actually used this. We then created a photograph to make it in a pictorial way of actually we all need to sometimes just get those sledgehammers out to break down the barriers. And some of it is about breaking down those barriers for people to get the assistive technology solutions that they require. I have been given his consent, by the way, to use the photo if he's not. But yeah. The next slide. So what we'll cover today is I'll share a bit about some of the digital inclusion projects that we're doing here in CNTW, and then both Beth and I will share on the importance of AAC. So one of our projects is a digital accessibility and inclusion training project. And the reason for this project is sometimes when people think about digital accessibility, we sometimes just think of the software and the websites and how they're coded. But actually, when we really think about digital accessibility and what it can mean, it then means that it's actually everybody's responsibility. Too many people don't know about accessibility features that are on our phones, on our laptops, that could benefit us all to use as individuals and our colleagues and our patient service users. And so a while ago, I was invited to a government roundtable event down in London for the public sector and digital solutions for disabled staff. And actually this roundtable event was housed in Microsoft's headquarters down in London. And before I went, I chatted to our exec here and I said, look, I've got an idea for a project on digital accessibility, and it might be that we could try and partner with Microsoft on this. And I'm going to the headquarters for the government roundtable event. And so we were in discussion, and they agreed that I could try and have this conversation. So we did, and thankfully Microsoft did eventually partner with us. And so we have got this fantastic project that is going on. And our aims for this project are that all staff understand the digital accessibility and why it's important, and for them also to create accessible experiences for other people, because you never know who actually you're going to meet that needs an accessible experience in the digital sense. Our other aim is that disabled and non-disabled staff to start using accessibility tools that benefit them, for staff to pass on the knowledge to other staff, to service users, carers and others, for service users, so our patients and carers, to use the accessibility tools that benefit them. And so, like I say, we've partnered with Microsoft. We've had exec sponsorship here. We've got our CNTW research team involved. I'm doing engagement sessions to staff, and honestly, they are amazed at what is on our laptops already that they didn't know about, and they're like, why did nobody tell me this? And it's just like, it's things like Read Aloud or Immersive Reader and all of these amazing solutions that then it's just helping people, people like tech, which we already have access to. I wish I'd known sooner. People are saying, why didn't I learn about this at school? So there's a whole education piece for the schools to kind of get on board and be like, right, yes, this is so important. And then what staff are doing is they're then completing the main training and filling out the impact survey. And we've had the feedback as being, people are saying this is life-changing for them. This is reducing stress. So this is our staff. But then also some of our staff are then telling service users and then even their own family members. And again, it's just like when we know that digital solutions can really empower and really help people thrive, it is when you get like, yes, this needs to be, we can't mandate it, but it is. We're having an amazing, it's just fantastic that people are getting on board with this. So if we can go to the next slide. The next one is, this will be happening in if you're in the public sector, I promise you, this will probably be happening in your place. And you might not realise it, you might realise it. So this project is about digital solutions for disabled staff. And for years of me doing the Disabled Staff Network, I've seen and heard that disabled staff do not always get the software and hardware that they need. So a lot of people may go to an Access to Work or an Knock Health workplace assessment, or come from another trust or another organisation, and they're getting recommended digital solutions. But then the software and the hardware is not being approved due to potential risk. So what we did is we then decided, okay, we needed everybody, the right people in the room at the same time. So we had digital, CSIRO, EDI, so the Senior Information Risk Officer, human resources, myself, other people as well. And we've just started to talk about this a lot more in depth of like, okay, why is this happening? And then we've sometimes invited the tech companies along, because sometimes our solutions that we have that is just, the mainstream tech, it doesn't meet everybody's needs who are in our places of work. So we do need to think differently and think, actually, we need to be able to be open to the thought that somebody might need another bespoke solution. So now we've been having the data protection impact assessments a lot more smoother, getting through quicker, and some approvals are happening. And then once the approvals happen, we then invite the tech company to come along and to demonstrate their solution at our network. And the aims are that disabled staff receive the digital solution that is recommended or a suitable alternative. And that disabled staff, when they go to a workplace assessment to say Access to Work or health, then they've got a list of approved technologies that are okay for CNTW. You know, we know that unfortunately some don't meet NHS regulations, and we are open. We do understand that. So, but again, it's so frustrating when you're trying to do your work and you can't, because if you've not got the solution that you need. We want, and also I've been advising the tech companies about, you know, looking at the data regulations for NHS and public sector a lot more, and displaying that on their websites of how it meets their, you know, how it meets our regulations, because that would save a lot of time and frustration. Our final project that we've been working on, go to the next slide, is about Microsoft 365 Copilot. So again, we do know that disabled staff can encounter a huge disadvantage in the workplace for various reasons, and it can contribute to the significant disability gap within the workplace. So our project is that to use Microsoft Copilot, which provides AI assistance. And again, we've been able to partner with Microsoft on this, and we're currently piloting the use of Copilot for disabled staff. And currently we're having fantastic feedback from the staff that have got the license. But what I want to say, and this probably is for everybody on this call, because I'm sure you will all be having AI policies coming through your door, or, you know, in your email boxes to like look at and to give feedback on. I think the big ask here is, even though we know that AI is going to be really helpful in leveling the playing field, we need to make sure that we include disabled people in the conversations about AI, and having and when we're creating the AI policies and the quality impact assessments, that it will include disabled people, because unfortunately there is a huge disadvantage if it's going on the LLMs, the large language models currently, and the disadvantages that it can create. So that's a big ask, please. The next slide, I'm just gonna I don't know if people have heard of the RixWiki or Signly. These are fantastic solutions, if you've not heard of them, that you might be that some of you might like to look at more. So we're just going to put those in the chat. But these are solutions that currently in CNTW we are looking at a little bit more. And if you go to the next one, so I do recommend you both all looking at those two solutions. So the importance of AAC. So like Rachel said, it stands for Augmentative and Alternative Communication. And we're going to today focus more on the powered AAC. So there's an aided AAC and there's aided AAC. And this is about, powered AAC is about the voice output communication aids. And that can be on tablets, smartphones, it can be dedicated hardware. A variety of vocabulary packages are available. The world of AAC is massive. It's not just a tiny part, it is huge. And as speech therapists, we do get training on it. It is part of the NICE guidelines. It's a huge area that me and Beth are very, very passionate around. And people can access through using their eyes, they can use touch screen, and they can use switch access. And today's session is not as training you on AAC, it's probably more on the advocacy side that we're trying to put across. So if we go to the next slide. We probably all know, or you don't know, because you might just take it for granted, I don't know, but the reasons for communicating are vast, absolutely vast. We can communicate for a variety of reasons, you know, of commenting, asking questions, social chat, slang, all the time. And I just want to, before I hand over to Beth, just share a little bit about just a few people that have really benefited on my caseload that I have permission to share about. There was one young child, and he was autistic, and he had quite displaying behaviours that were distressing sometimes, to the extent that he would rip up paper, and, you know, when I was doing an assessment with him, I'd rip things up. But because we had access to communication aids like technology, we were able to see actually that technology that helped him communicate would be really beneficial for him. And so we'd gone from somebody that wasn't really able to communicate much at all to now being able to do massive sentences and to share things that, you know, his mum at the time was like, oh, Mary is now able to do this and this. You know, when children begin to copy what you may say, he was starting to do that even and create full-on sentences. But if we as a team didn't have access to the communication aids, we would never know that because of what was happening for him. I've had other people, you know, recently that have during assessments that they've been able to communicate that they want to go back home. So they were out in the park. There was this child that I had in the summer, and he was able to tell his mum that he wanted to go home. He had enough in the park. Previously, it would have been probably, you know, quite hard for him to communicate that. One of my colleagues last week, she just told me with using one of our communication aids with a child, that the child had begun to say, I love you to the parents. That had never happened before. And so we know that communication aids are really valuable, and it's part of digital inclusion that we need to kind of help with the message that this is vital, absolutely vital. So I'm going to hand over to Beth, who is just going to, do an amazing job of sharing again of how important this topic is for us. I'll hand over to Beth.
Thank you, Mary. By way of further introduction, I wanted to just share a bit about myself and how I use technology daily. As this is an online session and you cannot see the resources I'm using, so I thought I'd start by sharing this photo of me sat at my desk presenting. I'm using my iMac to present. Then to my left is a second screen, so I know what you are seeing. Did you know there is a delay when you screen share? Offset to my left, I have an iPad Pro with software that gives me reliable real-time captions. I have a hearing impairment and normally rely on lip reading. This means I don't always get everything that is said online, so I can see what you say. In front of me is my iPad with speech software, which is pre-programmed with this speech. I have poor hand function, so my access to the iPad with the bespoke red stylus, and the Mac with the tracker ball. At the far side of the desk is my eye-gaze system. I cannot sustain using the stylus for all my communication needs, so I use this brilliant technology for answering questions. My eyes are basically the mouse, and I use them to navigate the package to type in what I want to say. I then activate the speech button, and you hear my voice. But I've already fallen into the trap of making this look easy. I pre-programmed my presentation, so it sounds like when I hit the button to speak, the words appear like magic. The reality is very different. Using AAC is not spontaneous, and it isn't fast. But it is effective, and it allows me to participate. If I was programming in real time, what I've shared so far would take just 10 minutes to input words. I was 4 when I started mainstream school. On my first day, I got an electronic communication aid and a BBC desktop computer that took up a whole table at the back of the classroom, so I could access the curriculum. That was 27 years ago. All my achievements since have been grounded in having access to electronic assistive technology and using augmentative and alternative communication, known for short as AAC. From the day I got AAC, I wanted other children who had no voice to be heard, listened to and understood. This passion has never diminished, although it has changed. I realized as I got older that children become adults. Having AAC is not a temporary fix, it takes a lifetime of commitment. As I got older, I met other adult AAC users, many with acquired or progressive communication impairments, following stroke, with multiple sclerosis or Parkinson's. Some had progressive conditions like my sporting peers. Then there have been those with temporary conditions, maybe following illness or surgery. I discovered because they previously had speech, the focus was quickly getting them back to their communication competence, or finding ways to preserve their speech output for the future, such as voice banking. The fundamental tenet of their competence to communicate was based on their assumed ability. I can't imagine anyone asking Stephen Hawking to prove he was cognitively able before giving him AAC. In direct contrast to this, most children have a very different journey. First, they must show they have failed to meet expected milestones. And second, there is a need to gain evidence they will be able to use AAC effectively. And then, if they are lucky and meet the strict eligibility criteria to receive powered AAC, they may be expected overnight to use it proficiently, whilst also learning alongside their peers who have speech. We hear all the time in the world of AAC that we must presume competence. In other words, work on the basis everyone can learn and grow, that there should be no prerequisites for AAC. I also wanted to say that having AAC is so much more than a voice. For many people, it is their alternate pencil, a way to access the world. We can use it for writing emails and reports, accessing the internet, and send text. It is more clunky than the mobile phone you all use for personal communication, but when we have these tools, they begin to level the playing field and allow us to participate in society on equal terms. There is a plethora of other tech available that helps many people. To name a few, they come in the form of reading pens, text readers, captioning software, access to artificial intelligence for summarizing reports, and the accessibility controls on our computers. It is an exciting time as it means making the workplace accessible for many more people. Both my degree and postgraduate studies have been at the University of York. I was spurred to study social policy because at the age of 14, back in 2008, I was blown away to learn that the United Nations Convention of Rights of Persons with Disabilities had come into force, and that electronic assistive technology and AAC were not only defined in Article 2 of the Convention, but that the right to communicate runs as a golden thread throughout the whole convention. To my teenage mind, this had to automatically make a huge difference for all AAC users. Overnight, I had an expectation of us all being empowered to share our views, opinions, and thoughts. I particularly liked that the articles advocated the need for family support and for highly trained staff to support learners of all ages, in all settings, especially schools. 17 years ago, it seemed like the world was my oyster. As I've grown up, it has become clear that whilst the right to communicate and have digital access is enshrined within the CRPD, it doesn't mean it happens. This has led me to continue to be passionate about and advocate for those who have little or no voice and need AAC. I've just completed a Master of Research, and sadly even today the provision of electronic assistive technology and AAC in schools is not automatic. In the UK, we have been good at signing up to treaties, yet there is a postcode lottery of provision. And getting an assessment means meeting stringent eligibility criteria. The result is that some people just don't get funding. It took from 2008, when the UK ratified the CRPD, to 2014 before we started to see legislation appearing that included the right to be heard for all adults and children. By 2015, government had included AAC as an intervention within the Special Educational Needs and Disability Code of Practice. Then 10 years ago, NHS England set up regional specialised centres for the assessment of those with low incidence, high cost, complex communication and access needs. There was an assumption that the then 42 clinical commissioning groups, which became the ICBs, together with local authorities, would then set up local multidisciplinary AC teams to support those with less complex needs. My research uncovered a diverse set of reasons for this. Just because policy exists does not mean it is effective. First, there is the way it is interpreted at national and local level, and then how this is implemented on the ground. My work has been to analyze the impact of this and determine if policy delivers what was intended. On one hand, I found the NHS regional specialised centres did the job they were set up to do, supporting children with complex communication and access issues. And where they existed, so did local AAC services who had highly trained expert practitioners. On the other, the expectation for local services never materialized in many areas, and now with the abolition of NHS England, we are already hearing that the provision of AAC is not a high priority in some areas. There are many reasons, ranging from pressure on funding, through to commissioners' misunderstanding of their statutory duty to ensure everyone has a means to communicate. But with the rapid developments in technology, it seems terminology and definitions of what is AAC also play a part in determining provision of equipment. Sadly, through all this change, many teaching and health professionals have not yet been upskilled to keep pace with what is needed. There is also a divide between assumptions everyone can use mainstream technology and the needs of those with communication and access requirements who need more specialized solutions. The result is the majority of children who need tech and AAC are being let down or slipping through the net. From personal experience, I know technology is life-changing. AAC is so much more than a box where you press a button and utter a simple request, or answer a basic question. With the right input and ongoing support, AAC becomes a resource to help individuals fulfill their own potential. In my case, to become a successful Paralympian, a postgraduate student, a policy geek, a workshop leader, a public speaker, and a mentor, who just happens to use AAC. But none of this is possible without hard work. Drawing on my Paralympic experience, I came across the claim it takes 10,000 hours of training to become a world-class athlete. I've been playing bocce since I was 10. As I went up the ladder, I was expected to train more and more. Eventually, this became a full-time job. In many ways, excelling in sport is like becoming fluent in another language, or becoming a world-class pianist who practices daily to stay at the top. This is similar to my experience of learning to use AAC. And I say this because my 10,000 hours of practice has been on top of the usual social and language exposure any other child gets. Most people don't give much thought to the fact they can talk. What I can say is that as an adult AAC user, being able to speak is always top of my mind. Is my device fully charged to start the day? How much charge have I got? When I travel or move to a new chair, where is my voice? Does my setup meet my evolving needs? Do I have the language and skills for my next challenge? I'm excited by the developments artificial intelligence might offer AAC users in terms of speed of output of communication. But at the moment, there are huge concerns around authenticity of output and the way large language models work. For instance, we all know word prediction changes our words to what it thinks we might want to say rather than what we are intending. Then ChatGPT doesn't always offer up what we want. Imagine wanting to say I feel unsure but getting offered I feel happy. Or, tonight I fancy wine and getting offered tonight I fancy you. Because that is what my phone predicted. The risks are that large language models predict what wider society thinks we might say and not what we as individuals want to say. This means, especially for children at the beginning of their language and literacy journey, we must apply caution. Getting assessed for and receiving a tech or a communication device is not a destination, but the start of a lifelong, often bumpy journey. Getting the resources alone are not enough. Success only follows when there are high expectations and high support environments. Being both given the relevant training and recognized as having potential to succeed is crucial. A quote from my research was, "You cannot be successful with AAC if you haven't got it." But this comes with a caveat. Everyone is unique and will have a different journey to their own destination. Because we are all different, the equipment we need is personalized. It isn't a case of handing out iPads and job done. The device has to fit the user. The assessment needs a skilled, multifaceted approach. It is not just the bit of kit, but how to access it, how it is mounted on a wheelchair, what software goes on it, what is the best language program, how will it be used for curriculum access, and so much more. To fulfill our own potential, we need a well-trained multidisciplinary workforce working across education, health and social care. They need the foresight, skills and knowledge to support digital inclusion. This means having a local AAC specialist team who take the lead. Where needed, refer to the regional specialized service, which were until recently commissioned by NHS England and now will sit with lead ICBs. As an aside, my research showed that these specialist centers do an excellent job working with the team around the child and providing the individual resources needed. The regional teams are then supposed to hand back to the local AAC service each AAC users for ongoing support in the community, whether that is in school or the wider community. For any user to be successful, they need well-trained communication partners within schools and the community, who have the time, skills, and experience to support the use of ATech and AAC in all settings, including at home. Families are the key to success. Children are in school less than 1/3 of their waking lives, which means communication opportunities abound at home and in the community. Where this support is available, we are seeing more young people going on to university in greater numbers. Those with acquired and progressive conditions also need their families' support with technology so they can either return to the workplace sooner or stay economically active for longer. In an AAC user's life, skilled communication partners are vital. With children and young people communication, this is about supporting them to develop skills that will sustain them into adulthood. We just want to be treated like everyone else. Remember, no one expects a child to talk in fully formed grammatically correct sentences until they are maybe 8. But even as an adult, it isn't easy. Society in general often look at people with communication impairments and assumes a lack of cognition. Ask yourself if you have suddenly found yourself speaking slower and louder if you think someone doesn't understand you. Have you ever started to change the words you are using to be more simplistic, or begun gesticulating and doing lots of thumbs up? Now, I'd like to briefly focus on some key areas of how I believe we can embrace the future together. When we get it right, individuals like me can go on to make a difference, contributing economically to society. That means first, early intervention matters. When all children undergo communication screening in the early years foundation stage of school, those with complex communication and access needs should not be exempted assessment or expected to sit through universal and targeted interventions, only to fail, but automatically referred for a specialist assessment. But getting a device does not make things plain sailing. 25 years ago, few people had computers in work. The only other one in my school was on the secretary's desk. This meant I was lucky. My teachers just treated me like the other kids because they didn't know what else to do. The good thing is that as of this academic year, all new teachers should be being taught at university about electronic assistive technology to access the curriculum, although we need a catch-up program for those who are current practitioners. Second, I class myself as a multimodal communicator. Like all of you here, I don't rely on just one method of communicating. My dysarthric speech is only understood by those I'm close with, in context, which is why AC is essential. Like everyone else, I use my voice, facial expression, my eyes, body language and gesture interchangeably. For us all, we rely on so much more than words to make sense of the world around us and create joint meaning. It was through meeting other AAC users I became confident to tell people the best ways to communicate with me. Simple things like be on my level so I can see your face and you can see mine. When I got to special school at 13, that I was introduced to using my eyes to say yes and no, actually a lifesaver when you are exhausted or ill. This is a vital tool in my communication armory that would have been so useful earlier in life. These examples show the importance of ongoing support. I'd like to think my own experiences don't exist today. Sadly, My own research has shown that this is still the case. Our journey as AC users is not just about acquiring language and literacy. It has to be about being prepared for the challenges of life and knowing how to help others to help us. Life doesn't stop when we leave education at 18, and nor should learning. Again, my own experience is if you go on to higher education, all support from an education, health and social care plan ceases. Life transitions can be challenging at the best of times for people who have no disability. For those of us who need a tech and particularly use AC, it seems we are often unwittingly set up to fail as young adults. My experience of university has been nothing less than supportive. Yet, there is no communication partner training available for academic assistance in higher education. If you get staff from a specialist agency, they are trained to support note-taking, work with people with autism, dyslexia, or sensory impairments. Ironically, when you have a communication disability, it's up to the individual student, like me, to train their staff in what's required. Two key learnings that were brought home since leaving school were as an AC user you need to learn to take responsibility for their own communication. The bottom line is that we don't want other people to speak for me, assume they know what we want or make decisions for us. I deserve for my voice to be heard. There should be nothing about me without me. Unfortunately, what we know is that before leaving education, speech and language input often stops, and in many cases as soon as an intervention is in place. From work I've led at Communication Matters, we know there are so many ways in which ongoing professional input could support disabled young people to have the skills to live independently, develop leadership skills, move into the world of work, and develop social communication skills. In principle, we can argue all the points I've raised are covered by national legislation and guidance. I have been privileged to contribute to the new Royal College of Speech and Language Therapy (AC) guidance. More recently, I was able to review the NICE transition guidance for moving to adult services. But guidance doesn't bring long-term support for adults with additional needs in the workplace or society more widely. Did you know that most children have exceptional healthcare pediatric support, but for many it stops at 18? Suddenly our specialist clinics disappear. Access services that know us well are no longer available. For instance, if you lost speech and language support in your teens, you can struggle to get an AC review. Things need to change. Children grow up to be adults. We now survive as long as everyone else, and if we are to be economically active, we need ongoing support, especially at times of transition and as our needs change. I mentioned my work as a trustee of Communication Matters, the main charity for all things AAC in the UK. I'm also patron of One Voice, a charity for children and young people who use AAC along with their families. Work I have specifically done with AAC users has shown they want to embrace their futures, they want to work and they want to contribute to society. The way in which they can do this means they need access and support to the right tech and AAC for them, wherever they live in. The hard work of communicating with AAC never diminishes, but with your ongoing support, practice and resilience comes the ability to fulfill our own potential. If I were to leave you with 3 messages, it would be to ensure the great work of the regional specialized centers for those with complex communication and access needs is not lost in the transition from NHS England to lead ICBs. The importance of local AAC services and joint working with education and social care to ensure good practice around the use of specialist assistive technology and AAC in every classroom, and this includes ensuring CPD is available. Please do not leave this to chance. If you have the influence, make sure commissioners and professionals are accountable for a tech and AAC are accountable for implementation. We all know what gets monitored gets done. Finally, we are in a golden age. Electronic assistive technology is here to stay. We need to act now so we do not leave anyone behind. In the words of Emma Watson, best known as Hermione in Harry Potter, who is also a United Nations ambassador. If not me, who? If not now, when? It is the responsibility of us all to make this happen. Thank you for listening.
Thanks, Beth, so much. I think we've had so many comments in the chat, and it is such a privilege to know Beth and other AAC users. And I think that's why when I said to Rachel, when she asked me to share on what we do in speech therapy, I was like, I can't do it without an AAC user, because I think it just comes such a privilege to hear from you, Beth. So thank you. And I think just we are about advocacy and action and what's next. And I think it's just, you know, obviously as a regional group here today, just to explain a little bit about the Northeast on the topic of AAC. So in the Northeast, we do have the special, like others that Beth has mentioned, we have a specialised hub. So it is a set of national referral criteria for assessment and to obtain AAC device for long-term life, but with support from a local AAC, a local team. So in our region, that's the Regional Communication Aid Service. It is actually housed here in CNTW, so I do work very closely with them. It does require a speech and language therapist from a local team to always be involved in any of the referrals that are given to an NHS specialised hub. So, but as Beth has touched on, we know in local services there's a massive unmet need. So with the specialised hubs, that they're supposed to do 10% of AAC, but me in a local team, we're supposed to do the 90%. And this is what Beth and I are wanting to have further discussions about and at commissioner level, because it is an unmet need. And so we know that local services currently, so whether speech and language therapy services or in education, they may not have the resources, the specialist knowledge, the funding for AAC assessment devices and software. It's not just about giving somebody kit, it's about that huge support that is needed, like Beth has explained. And then about some places don't always have the funding available for an individual to have AAC device for life. So that's in the local part, the local services. So there's a huge unmet need. So the local NHS team I work in, just to explain, so we actually have access for someone to have funding for somebody to have an AAC device for long term, for life, well, sometimes, you'd have to, get them a new one depending on the longevity of it. But actually what's interesting is we don't have funding for enough AAC assessment devices and software to carry out our clinical assessments to gather the evidence to apply for the funding. So we've got the funding to apply for somebody to have a long-term loan, but we've not got enough assessment devices. So I suppose my ask here, like Beth has said, if there's anybody influential on this call, to follow that conversation up, because I can tell you now, there's so many, there is people that are waiting for our assessments that we can't fulfill that fully at the minute, and which is really, really sad. So if we go on to the last slide. And like I said at the beginning, I had the fortunate opportunity to go to ATIA in America in 2024. And I met somebody who I'd followed for years in the AAC world. And this young person is called Jordan Zimmerman. She's an autistic AAC user. She's a non-speaker. She wasn't given an AAC device until the age of 18. We haven't got enough time to show her video, but it's awful kind of what happened to her and what people's presumptions, because she showed distressing behaviours. She showed various things that people just were like, kind of judged her. She is now somebody that advocates on a daily basis, and she speaks across the world. She's spoken to the previous American president about this as well. And I'll leave you just with her final words. You must do a better job of ensuring that each of us who need it is given access to use robust communication devices that work for us as early as possible. Too many people like me are written off, subject to lives of oppression and segregation. Too many educators, health professionals, caregivers give up too quickly or assume we cannot learn to use language when we fail to use spoken words or picture cards in expected ways. People like me shouldn't have to rely on luck or chance to be seen as worthy. So thank you very much, everybody, for having Beth and I here today to share.
Well, that was fantastic. I think you've certainly, as you can see from all the comments and the hearts, you've certainly touched everybody today, which is fantastic. So thank you. Just a few words from me. It's been absolutely brilliant for Mary and Beth to not only give their time today, but really being able to open up and sharing their own personal stories. And when that's vulnerable, that can be quite hard, but we really appreciate that approach. I think your honesty's helped us feel feeling seen, and advocacy for me shone through completely, and how both of you are doing a consistent job in making sure that you kind of pushed that advocacy to make the world a kinder place for people and make it more inclusive. And some of the top things that I'm taking away, and I'm sure you've all got some things that you personally will be taking away, is the importance of PPIE. I think you touched on that at the beginning, Mary. Ensuring like lived experience shapes the pathways, the work that we do, and I think that's just essential. We don't do enough of it. How valuable technology is when it's designed with people and not just for them. I think that's really important. How, I guess what Beth, just to say, I also studied at University of York. I did a postgrad there, so it was nice to see some personal connection. So that's great. For me, the reality of the postcode lottery, which Beth touched on, which is just shocking. That really, from an equality perspective, we should be trying to spread that far and wide as much as we can. For me as well, it's about the policy. It isn't just about that being there. It's about the difference that people can make, because change only happens through people. You can push as much policy to us as possible, but actually it needs people like yourselves on the ground to do difference, which I think is great. For me, we must deepen our understanding of some of those barriers that individuals face. You know, even Mary touching on the fact that they haven't got devices to do assessments, and actually need those to understand what those challenges are and how best to provide. And for me, the final thing would be around, this has got to be ongoing. It's not just a support somebody wants. Lifetime support should be provided. So that was just a few reflections from myself on listening to both of you today. It's been truly inspiring. We've had some of those comments in here as well, which have been fantastic. I hope you can stay on. We've got the wonderful Sonia Townsend from Ways to Wellness joining us now, and that's touching on social prescribing and digital inclusion, completely different presentations, but equally of value. But as I said, please do stay on. So it's over to you, Sonia. I'm going to swap the focus.
Thank you very much. How on earth am I going to follow that? That is not fair. That was amazing. I've copied down all the links, so they're sitting in my tabs at the top now. So yeah, I'm going to really try very hard to follow that. So my name is Sonia Townend. I am head of digital systems for Ways to Wellness. I'll introduce myself and then I'll start up the presentation. We operate across Northeast and North Cumbria, although we're based in Newcastle. Our office is down on the Newcastle quayside. And we support organisations to, for example, DWP, the NHS. We've got projects running in primary care and secondary care to transform ideas into practical actions. We do quick prototypes, we do long-term pilots, and everything in between. We've just completed a 10-year pilot in Newcastle primary care, supporting people with long-term conditions. And we're also doing smaller pilots with 30 clients across 6 months in order to sort of provide evidence for bigger bids and further projects. So we utilise the social prescribing link worker model to support people with non-medical needs in order to improve their health and well-being in general. One of our strengths as an organisation is that we use assessment tools and sort of strong data collection. So we do the nice things, we support people, but we also measure that impact and sort of provide those outcomes for sort of bids and sort of larger projects. We do find that, I'm going to start my presentation now. We have 4 current projects, and that's everything from sort of primary care, secondary care, tertiary care. We've got a project in the Great North Children's Hospital. I think this is going to start from the beginning. Rachel, can you give me a thumbs up that you can see my first slide?
Yes, we can see that.
Amazing. Thank you so much. And we don't have digital inclusion as a separate project because we found that it's a thread that runs through everything. Pretty much everybody is touched by sort of technology, the internet, and it affects their life in some way. Patients are often referred to us through the different projects for other reasons. We don't get people coming seeking support from a link worker because they can't get on the internet or because they need a device. It's very often for something else. And I've got some nice examples of that. Is everyone familiar with, if you're not familiar with, the periodic table of internet access? I'll drop a link in the chat just in case you haven't seen it. I do feel a bit like I'm preaching to the choir with this. But you can see on there that access for people is not just around healthcare. If you can get someone access to the internet, get them digitally enabled, get them the things that they need, it affects all areas of their life. And we can see that in the sort of case studies that I've got here. So the first one I'm going to start with is Amina. So all of these case studies are, we've changed names, we've changed details, we've amalgamated some things, but these represent the people that we are supporting. So Amina is a Somali woman in her 30s. When she was referred into us, she was living in sheltered accommodation. She was awaiting a Home Office decision. So at that point in time, she had no recourse to public funds. She had been a domestic violence victim. So that's the reason she was referred into us, to sort of support her through that experience and help her get her set up in a sheltered housing. After the link worker spent some time with her, they sort of found that she was experiencing extremely low mood, as you'd expect, and quite a lot of anxiety around her situation. So the link worker worked with her on that and just sort of getting her referred into some counselling that she could access and just being that sort of point of contact for her. Even though she didn't have the right to work in the UK, she was very keen to get working. She'd been a sort of skilled worker in Somalia before she'd come over here. So she was very keen to sort of learn new skills, improve her English, and just start signing up for some courses. So she was ready to go when she got that decision. So she was being supported by our maternal mental health project. So at that point, I think she'd just given birth. So she had a sort of newborn. She also had a 3-year-old little girl as well. So she had all of that to sort of deal with. She had no device, no access to a device. She was living in a house of multiple occupancy, so she had no access to Wi-Fi. So the link worker put her in touch with Furbed, who provided her with a laptop, which meant she could sign up and start doing some courses. We gave her some options for accessing data. And even though it wasn't the cheapest option, she went for a data device, which meant she could run a small TV, which meant when she was accessing the courses and working on her education, her little girl had something to keep her entertained. Because I don't know if anyone's ever tried to do work with a 3-year-old running around. Not easy. So you need something to sort of distract them and keep them occupied and all that sort of stuff. So we helped out with that. All of these things are available. If you know where to look, you can get devices, you can get data. But the sort of really highlighting with this that she needed something a little bit different. She didn't need a SIM card. She needed a device so she could run several devices from that. She had no recourse to public funds, so a lot of the things that were available she might not have had access to. And she didn't know where to look. So the link worker put her in touch with these people. We got the device, we got the data. We identified the courses that she was able to access without that sort of UK residency status at that point in time. So like I said before, we use an assessment tool called the Triangle Wellbeing Star, and that looks at a person's different areas of their life. So they look at sort of health, and they look at housing, and they look at the social side and all that sort of stuff. And across all of these case studies, we saw significant increases across all of the parameters there. So not just in the ones you'd expect around, sort of access to work and all that sort of stuff. All of their sort of parameters went up around being able to sort of look after themselves better, access to finance. It just sort of improved it across the board. On the same project, so on the maternal mental health project, we had another mum that was autistic. Not sort of our typical sort of client in that she was quite well educated. She lived in a fairly sort of affluent area, but because she had suspicions around the internet. She didn't feel like it was a safe place to be for her and her child. So she chose not to access the internet or anything digital at all. And she really struggled because of that, because as you know, a lot of things now are digital by default. So a lot of the role for the link worker in that situation was being an advocate and a link between her and the NHS, the DWP, her employer, when we got sort of closer to employment, and around figuring out ways that didn't involve digital. So I know it's sort of going against the grain a little bit, saying digital isn't always the solution. But you know, sometimes it isn't. It needs to be an option, not the default. So the next case study I'd like to share. We had Terry. Terry was a lovely man in his 60s. He was functionally illiterate. So he had really struggled at school. He'd had a bit of a tricky start to life. They reckon looking back that he had dyslexia, and the school that he went to just wasn't equipped to sort of support that. So he left school with no sort of qualifications. He was unable to read or write. He did develop a passion for car mechanics. So he's done a lot of sort of car repair and sort of classical car repair. This was also made even more difficult. His situation was made more difficult because of something that happened in his early life. He was on the witness protection scheme. So he had no access to his original birth certificate. He didn't have a passport. He didn't have any ID. The ID that he was given when he went onto the scheme had all been lost, and he had no idea who to contact, how to get back to that. So he had nothing, which made everything really, really tricky for him. He had quite a few health conditions, so he was backwards and forwards to the GP, and that was actually the reason that he was referred into us. They said, look, is there anything you can do? He's coming in with non-medical reasons, or he's coming up with what he describes as medical reasons, but they turn out not to be. So we got to spend some time with him, got to the bottom of sort of what was going on there. At that point in time, they didn't actually have a note on his record that he couldn't read or write, so they still continued to send him letters. So the hospital still continued to sort of send him letters about his long-term conditions. So every time he got one of those letters, he had to find a family member or find a neighbor to read some of those letters. And they weren't all about things that I would necessarily want to share with a neighbor. So that was obviously an issue. He did actually have a smartphone. His son-in-law had given him a newish sort of Galaxy device, but other than receiving calls on it, he had no idea how to use it. And he would just sort of, he'd started to not answer the phone because he wasn't sure who was ringing him. I know if it was the DWP again ringing about, why haven't you responded to our recent letter, or why haven't you been logging into the app? You know, it was really upsetting for him. It was really starting to affect his mental health. So we spent some time with him, and we started switching on all of the accessibility features on his phone. Just to sort of hark back to the previous talk. There are so many features on phones now around accessibility. We enabled the screen reader for him, and honestly, you'd thought we'd waved a magic wand. His phone could now speak to him. So he could read his text messages. He could then access the DWP app and see what they're sort of going on about. I showed him how to, so spoiler alert, this was actually one of my patients in a previous role, with quite a few details changed. I showed him how to set up profile pictures. So when people were ringing him, he could see who it was. So I took a little selfie and saved my picture into his phone, showed him how to do that. And even if it wasn't a person, if it was the DWP, he could take a picture of a logo or a picture that would remind him who that was. So he felt a bit more able, even just to answer things. Showed him the speech to text, so he could then write his own text messages and sort of respond to things where he couldn't before. And because we got all those things set up for him, we were able to enroll him on a literacy course, whereas previously he couldn't, because he didn't have any sort of access to documents, or he couldn't search the internet, really basic things. So we got him signed up for a literacy course. We figured out a way for him to get a birth certificate because he needed to prove UK residency to get on this literacy course. And we sort of supported him with his DWP. We got him on the NHS app. We sorted out his sort of PIP payments, so they then agreed to call him rather than send him a letter, and just sort of sorted a few things out for him. We had to have some quite strong conversations with the local NHS trust, the hospital trust, because it's actually really difficult to get anything other than a letter. You can get it in large print, and that's about it. And getting the different departments to sort of talk to each other, we had to actually raise a few complaints and go to the ombudsman to get those changes made. So yeah, we had to be a real sort of advocate for Terry. And then yeah, so he was quite grateful for that, and he gave me a ride in his classic car that he'd been repairing. So yeah, so that was a nice one. The final one I'm going to share with you today is Jenny. She was, this wasn't one of my patients. Jenny was a retired GP. She was in her 70s. Again, not our typical client. We often see people from sort of disadvantaged minorities, from the sort of poorer parts of Newcastle. Jenny lived in a very nice 5-bedroom house in a very sunny, in a very leafy part of Newcastle. But since her husband died and since she retired, she'd become very, very isolated. She had an iPad, she had an iPhone, she actually had 2 iMacs upstairs, one for herself and one that belonged to her husband, and had no idea how to use any of them. She just thought, well, people have got iPads, I should have an iPad. So we just sat down and showed her how to use those. She had family in Australia that she struggled to keep in touch with, so we worked on sending emails. We got her set up with I can't remember if it was Skype or Zoom, so she could do video calls with family. So she actually got to see sort of grandchildren and children, which was lovely. She started signing up for educational courses. She started online shopping after we'd done a sort of short session with her around how to do that safely and how to sort of protect bank details and all that sort of stuff, because there was a lot going on around sort of confidence. She also, one of the main reasons, one of her biggest bugbears as well, was that she lost all of the family pictures and voice recordings from her husband because they were locked up on his Mac. So we got the help of a sort of local community shop, a local computer shop, sorry, and we got access to that iMac, and she managed to download all of the family pictures that were stored on that computer. All the voice notes, all the voice recordings that her husband had made when he was, because he sang in a choir, that's what it was. We got her involved with the local community choir through their sort of Facebook page. So we got her a lot more sort of socially involved, and they also have the sort of social group around the sort of choir singing as well. So yeah, just some very sort of minor things, nothing too technical, literally just sitting down with a person and showing her how to use Facebook, showing her how to use video calling, giving her a little bit of confidence around shopping and getting in touch with people, made such a difference to this lady. And she's been a real sort of advocate for the projects, which has been really lovely. So yeah, just to sort of emphasize, there are some really good resources for data. You can get SIM cards from the Good Things Foundation. You can get devices from a few different organizations. There's all sorts of local skills development, training courses, workshops. running, you just have to know where to look. There's lots of issues around trust. So people don't trust the internet, they don't trust AI. And even if you address all of those, it's only part of the solution. So our social prescribe and link workers are a really unique position in that they can spend an hour or two every week with a patient. They can go out and visit people's houses and actually get to the bottom of, find out what matters to you as a person and what do you need? How is this affecting you? Digital exclusion is quite often not their only challenge. You can't just get away with just giving somebody a device and putting them on a course if they haven't got any food in the fridge or they haven't got any electricity on the meter, or they're worried about their kids staying in school. So if we can look after those alongside that, we can make such a difference. If you can get somebody digitally enabled, you're not just affecting that one thing that they've come to you with, it's accessing, a social life. It's accessing all the NHS app and all that's got to sort of offer to people. It's seeing their maternity notes. It's being able to communicate with the DWP. It's being able to do some online shopping. It's being able to, join choir groups because you can actually get on Facebook now. So many different things that you can sort of sort out just by spending the time and not necessarily being good at computers. You don't have to be the sort of digital guru. You need to be good with people so you can figure out what matters to them, and everything else just falls into place. The link worker has such good connections, they will figure it out. So yeah, I think that sort of concludes what I was saying. Thank you very much for your attention. I'm assuming people will have email addresses because I know people are already dropping off the call because they've got other things to go to. If anyone wants to drop me an email either through the website or just sonia.townend@waystowellness.org.uk, I'd be more than happy to answer any queries or questions.
Well, thank you, Sonia. That was brilliant. I always love hearing the stories because that's about the difference, isn't it? It's those top tips to other people. And I think that's always just so empowering. And for me, it's about, the difference a bit of time can make to somebody's life. So you mentioned DWP, getting access to Facebook, etc. Sometimes it's not about that formal course, which often I know is about funding, but you go on a 10-week course, it's an hour each week, etc. Sometimes it's just about that simple approach that says, let's just spend a bit of time side by side and I'll show you how to do some things. And I think that's really, really positive. And some top tips, I think, as I say, other people will take some top tips away. They'll have their own experiences as well. But there's an opportunity, look for devices and data. If you haven't already, sign up for the Good Things Foundation because that's enabling you to get data to be able to give to somebody, and how empowering that can be. We also talk about MECC, make every contact count, and I think that's really important. So our workforce out there need to be aware of that, and how can they just spend that little 5 minutes of their time helping somebody with the NHS app, because actually we'll reap the rewards further down the line. And to me, that wider impact will really just help support that good cause. So that was just a few of my reflections, Sonia. Always great to hear you. First time I met you, I just know your passion about these subjects. And it's really brilliant. So without further ado, we've run 4 minutes over. I do apologise, but that's absolutely great. We've had some brilliant content. We wouldn't have wanted to miss out on that. I'd just like to thank again Mary and Beth for joining us today. I think it was such an inspiring, empowering conversation and presentation, but also to Sonia for giving us some time to bring it to life about some of the challenges that social prescribers see on a daily basis. So please have a great rest of the week, and we are back in March and we will advertise and let you know what the subject will be. We're hoping to get a special lineup, although I'm going to say it's hard to beat today's, but we will let you know as soon as we've secured the speaker for that. But thanks everybody for joining us today, and enjoy the rest of your Monday. Take care.